I just wanted to give you a really quick little run through of what sexual health across clinical context, the subject that we're running for the medical students, and then get you a chance to experience some of the ideas and things that happen for the medical students. So I'm going to interview 4 of our lovely panellists who I'll introduce after I've given you this spiel. First of all, I did name it Sexual Health Across Clinical Context. So remember when coming in to first introduce this to the search team and they all went, oh, like that is really a very boring kind of name. But I did it for a couple of reasons. I wanted the medical students to know that this subject was going to be clinical and practical. I'm a very practical person. And also that sexual health crosses all parts of medicine. So it's not, I'm trying to make mini sexual health physicians. I'm trying to make people who are in any type of medicine field that they will be able to be comfortable when a sexual health issue comes up, or they might actually introduce it to the area of medicine that they're dealing with. I do want to acknowledge the country that we're on. We are on Yorta Yorta land. I like to begin a lot of our sessions with the students talking about the fact that we're on unceded lands, and that hopefully we are continuing that idea of storytelling, of talking. I agree with Jack, we are losing the art of talking, and we really need to talk and listen to our patients. So back in 2022, the University of Melbourne's medical degree was redesigned. It's a 4-year postgraduate course that's been going on for more than 10 years now. Each year is worth 100 points. And in this redesign, the students were allowed to choose an elective, and the elective is worth 12.5 points for the first 3 years. So at SEARCH we decided to design and develop, and we now manage and deliver 1 subject a year for the first 3 years, and we've called it, because my creativity is really about 0, SHAC 1, 2 and 3. The other thing that we do, because we are the Centre for Excellence in Rural Sexual Health, is we deliver this for metropolitan students and also rural students, and we don't just stick the rural students online. The experience for the rural students needs to be the same as for the metropolitan students. So I do believe that the cornerstones of good sexual and reproductive health is communication, and we teach a lot of communication skills through sexual history taking. We're trying to break down the taboos, and I like to frame it in that you're having sexual health conversations with your patients. So what I'm going to do is just run you through a list of the things that we actually present to the students, but you will see that the overlay of all of our work is really around these things of communication, taking a really good sexual history. So in first year, we have some asynchronous learning, online learning, do it at your own pace. The synchronous learning that we do is we start talking about sexual health research, so Meredith. So a lot of you in the room probably know all this because you're part of it, but Meredith Temple-Smith explains to the students what sexual health research is, and it sort of starts everybody off with a bit of a buzz. Then we do sexual history taking, we do small group learning, and I'd have to say in those first 4 weeks, the students sort of go from being embarrassed of saying penis and vagina and working out what everything is, to being almost bored with me saying, no, repeat it again and again, and let's keep going. And we also do cover stuff around safety and clinic setup and how to make a clinic appear inclusive of anybody who wants to actually access it. We cover epidemiology, we do STI lectures, and so they're on chlamydia, gonorrhea, mycoplasma genitalium, syphilis, herpes and HIV by popular demand. The first year I didn't do HIV, the next years we've added it in. And then of course when your centre is run by a world expert in partner notification, you wrap that whole thing around of all your STIs. If you can actually deliver really good partner notification, you understand the STIs. So the Simple little statistics. We do a lot of student evaluation, and I just like looking at this graph. Really just look at the shape of it, but it's basically saying when people come in before starting first year, they is a smattering of whether they feel confident or not about talking about sexual history taking and having sexual health conversations, and then by the end of it the majority of them agree or strongly agree that they feel really confident after our subject. So moving along to year 2, we start ramping things up. Of course, we still talk about communication skills, but we look at interprofessional care. How are different people within the within clinical fields doing sexual health? So we have a GP, a nurse practitioner, OT, and a pharmacist talk to them about how you deal with one patient. So we do it through one patient case study. They do genital anatomy, and we start off the anatomy lecture talking about female genitalia. If you've ever opened an anatomy book, it always starts with the men and then moves to the women, and the women end up getting about a paragraph. So we've kind of flipped that on the head. And then we run a world first vulval dermatology pain workshop that then also includes the students learning to do a vulvar examination, which is not taught anywhere else in the world. And they do this with the other program that I'm involved in, with the sensitive physical examination program, where the tutors teach on their own bodies, so they actually get to practice doing the vulvar examination. And then that means that we do a whole lot of stuff on STIs and how to actually, not just this is chlamydia, but how do I actually explain this to someone? Yes, you've got chlamydia. How do I take the test? How do I actually tell you to walk down the corridor and pee in the jar? How much? When to, open the jar lid. Don't sit on the toilet and then think about opening the jar lid. So just really simple, practical things like that. We then actually move into more complex patient management and do that through the lens of HIV, transgender medicine, and patients with addiction. We do run a workshop on sexual difficulties. I get the rest of the search team involved in the health promotion. They learn all about that health promotion is not just a pamphlet. And we have a talk given by a lawyer called Consent, Capacity and Mental Health. And the students, I thought, this would be something different. The students have really loved that. I get a lot of feedback about how it's really good to hear that from someone outside of the health realm. And I'll show you this from the last graph. Flip it upside down. So Sophie Stewart is the coordinator, and she's the one who's done these graphs and the next graph, and they look much better than my first attempt. But anyway, it's sort of showing you that people the students really get a lot of confidence throughout on running an STI consultation, working out what normal genital anatomy is. They really appreciate doing the vulva examination. And we do an exercise with the interprofessional care. One of the assignments is they have to write a referral, and I get a lot of feedback as well about saying, I've never done anything that practical in my medical degree, something that I know that I'm going to use later on. So moving on to year 3, getting even more practical, and I'm pleased to say from our previous speakers that our MD3 students leave being able to, on day 1 of being a doctor, they will be able to they'll be able to insert implanons, and they will be able to provide medical terminations of pregnancy. So they will be prepared. They get a chance to go to clinics, and I know a lot of people in the audience here have been involved in our clinical placements, and the students love the fact that they get some really practical experience. And as one of the students reported back, that on her birthday she got to implant or insert an implanon. It was the best birthday present ever. So we do also cover some of the more difficult and challenging subjects about talking to people about ageing, sex and disability, about coercion and non-consensual sex. So the students get this really broad broad cross-section of sexual health and some of the practicalities of that. And I'll show you the next graph, which sort of goes over how we're kind of making people more and more confident as they leave our course. But I've given you a whole list of explicit education that we provide. There's a lot of implicit training, showing people how it can be done, getting people placements where they can see that this stuff can be done and done really well and actually affect and change people's lives. So I do want to kind of acknowledge the fact that the search team, it's not just me up here doing this, the search team has really supported and has always helped me deliver all the subjects across now that we're running all 3 years. And you know, I'd want to thank their participation in helping me organise placements and all those sorts of things. But I do really want to also thank the students, and so you get to hear from them at the moment, because it's made my job absolutely fabulous. And I don't know whether you've got a chance of, because we're called SHAC, we thought of the Shack. So down in where all the posters and things are displayed, we've got the Shack down the end, and that shows all the different reflection pieces over all 3 years, the students participating in those, and we really wanted them to be as creative as they wanted to. We've got rap songs down there, if you want to turn on the computer down there, poems, but just really fabulous insights into how this subject has actually helped them along their medical journey. So, without further ado, let's hear from the students. So first of all, we've got Coco Moisey, Brooke Cairns, Simone Morris and Solana Cheng. Okay, so I've been told to channel my inner Drew Barrymore, but I don't know whether I'll be able to do that. Anyway, there will be no free couches. Doesn't she give away stuff? I won't be doing that. Anyway, so I'm just going to, first of all, start with Coco. She's right next to me. When you started SHAC, what did you expect? So thinking back, what were your expectations as you kind of walked in?
So I guess thinking about the whole MD course, we don't really have a lot of sexual health teaching in general, so I didn't really know what to expect. I thought it would be pretty much just STIs and treatment, and it turned out to be so much more than that. Yeah, I guess just the practical aspect of it was amazing, getting to have all the hands-on experience in the sensitive exams, and like getting to learn about MTOP and implant insertion. It was just so much more than I expected, yeah.
I'm also going to get Simone to answer that question. What were you expecting when you first kind of came in?
I think I had pretty similar expectations to Coco. Sort of thinking we'd learn basic skills on how to take a sexual history, practice with each other like we did in normal classes, and then maybe a bit about STIs and treatment and stuff like that. But
was there anything that actually really surprised you?
Yeah, I think like on taking sexual histories, you got like actors in for us to take histories from, and that was so much harder than taking a sexual history from.
Half of the actors were the search team, just to let you into that.
I still like, when I see these people around, I like recognize them from videos that we had, and I'm like, oh my god, you're like famous. Yeah, so like that kind of stuff, seeing like interdisciplinary roles from different like OTs, nurses, lawyers within sexual health. I wasn't really expecting. We haven't learned anything about sexual difficulties outside of like, sometimes erectile dysfunction could be a heart attack. Or diabetes. But like, like nothing about how to talk about that. And I also was surprised how transferable the knowledge was outside of sexual health. Just like how to talk to someone and ask them difficult questions and listen to their responses, and how to refer people on for support. Because I think even in first year, we talked about sexual violence and asking people if they've ever been assaulted or been a victim, and to ask them like if they want to talk about it, if they're okay, if you can provide support, is nothing we've touched on until maybe like our women's health in third year, before which like they're like, they exist, but we'll get to it. It's not, yeah, it'll come up later. We have maybe a week in first year. Yeah, so.
Cool. Did you want to add anything that surprised you at all, Coco?
Yeah, so being one of the rural students, I've only ever done rural placement and didn't know that I had the opportunity to do a metro placement. And then I got to do a week at the Royal Women's, which was incredible, very inspiring, so great to be in a metro hospital, just see the completely different way that it worked. Got to be in the abortion contraception services clinics and in theatre as well, and just the support from all the staff there was amazing. So I think that would have been a real surprise to me that I would get to do some time at such an incredible hospital. Yeah.
Awesome. All right. So, Solana or Brooke, do you want to talk about anything that you think we may have missed?
This took me ages trying to figure out different things that I actually missed in the 3 years of doing this. But one thing that came up yesterday in Starling's presentation was body dysphoria and the idea of trying to navigate consent and intimacy when you do have body image issues or gender identity crisis, I guess you can call it. So I think that's probably the only thing I can think of that was missed. I don't know if you have any.
I also find it really difficult.
Sorry.
In working with the Department of General Practice, we have a friend doing a research project on how to get young cisgender heterosexual men involved in sexual health, and it's really hard. It's really hard to recruit, it's really hard to ask them questions about vulnerability, and I think, I don't know how you would start teaching those, maybe get a speaker in, so we can disseminate that information. But I thought getting cis het men would be really cool. And then I was only in the first 2 years, but I also thought more like talk about abortions, more talk about miscarriage would be relevant. As someone kind of mentioned or alluded to, we talk about it in women's health, but it's kind of like there's not enough space to go into miscarriage or abortion clinics for medical students and registrars who need to see it. And it's not really taught other than doing like the spikes method. So that would be really great, but I don't know if there's space in the first 2 years.
Yeah, we have sort of thought about it a lot, and I have ideas of how we can kind of change that, even just including it more in the sexual histories that we make you take. The interesting thing is one of the assignments that the students do in first year is they create their own patient, and then they have to take a video of themselves taking a sexual history from the patient. These guys will all remember doing that. And this year I've had an increased number of students making their case have a pregnancy and abortion, whereas previously that hasn't been. So I think if I can emphasise that, that will actually move that part on. So thanks for that. Were there any particular sort of aha moments where you went, wow, that was something I wasn't actually expecting? You've got the mic, Solana.
I think it's sclerosis. To have a personal anecdote, I was in GP and I had this woman who just was like, a follow-up outpatient pneumonia, and I was like, oh, how you doing? And she was very unwell. So I was like, okay, let's get you to a hospital, blah, blah, blah. And then I did the differentials, for like, why are you sick? Is it pneumonia? Is it a UTI? Is it like blah, 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 blah. And it was kind of pneumonia, it was actually COVID. But I screened the UTI and she's like, oh, it's so painful to pee. And I'm like, oh my God. But then she started crying and I said, are you delirious? And so I said, call 911. But 000.
We're watching out for Mary.
Canadian. But then she came back 2 weeks later, and then I was like, blah, blah, blah. Okay, how's the peeing? She's like, and then she started crying again. I was like, oh my goodness, what's happening? And she talked about how painful it's been, and that antibiotics don't work on her, and that she can't really feel or see what's going on down there. So I was like, we're gonna do an examination. I'll call back in my GP supervisor, but I have a hunch on what this is. And it was exactly what the lecturer had on the screen. It looked exactly like it. She was an older woman, hadn't brought up her sexual health in like decades. Didn't bring up the UTI other than, not UTI, but didn't bring up the dysuria until I asked about it. So I thought that was a very key learning.
Good story. Brooke?
Yeah, I had a similar personal experience from a GP clinic in Coral, which I mentioned before. There was a patient that had come in, and I just couldn't believe that I was getting to like, wow, I'm ready to do this consult. I have been prepared for this for so long. And it was an older gentleman that had erectile dysfunction, and I think he thought he might have had an STI as well. And he's like, oh look, I don't want to show anything, you're a female, I don't want to talk about this, it's so embarrassing. I was like, what are you coming in for? Like, it can't be that bad. And he's like, oh, I need to take my pants off to show you. And I was like, it's fine, like I've seen this before, it's okay, you can do it. And it was just amazing how the course had prepared you to have that conversation with this patient and make him feel comfortable enough for me to be in the room for the examination itself. Because at the beginning of the consult, he was not having it, to put it frankly. But the course has well and truly prepared you to have those difficult conversations, to be empathetic and communicate, and be able to even just talk about sexual relations and intimacy with people that are within that older age bracket that probably think they're forgotten about and that sexual health is not important anymore because they are within that older age group. I think just having those personal experiences was pretty awesome. Yeah.
Great. So can you tell us about how taking SHAC in any number of years as a subject has informed what you think you might be doing in the future? This is open to anybody.
Yeah, I can start that. I think just like everyone has said,
so we've got a really good relationship with them, and we're continuing to get a lot of barriers for people working in rural and regional areas. And
you're just so much better prepared to have the difficult conversations. It's so much more normalised. I don't feel stressed about it. It's just a part of the consult. In the future, I'm hoping to work in paediatrics, but could definitely see myself working in a school, taking this all this education that I've got from SHAC and using it to my advantage.
And your patient's advantage.
Pretty similar to what Coco said. It's just definitely prepared you to have those difficult conversations and just communicate with ease. Like, I don't feel uncomfortable going into a conversation, about a miscarriage or terminating a pregnancy. You just feel a lot more confident being able to actually talk to patients, take the history, and you can just sit back and relax almost when you're in a GP consult and just actually have a conversation with a patient.
Yeah, I think similar things, just having the confidence to ask difficult questions to patients. Like, I had a patient in ED who I went to see who I think had abdominal pain, and she was married and no one had asked her if she had multiple partners, and she did. So like, just having the confidence to just say, like, even though like when I went in I was like, oh, I don't need to ask this, I'm not going to ask, and then I like heard Siobhan in my head and I was like, I'm still going to ask. And then like, I feel like all those cases where I feel like I don't have to do it and I do it, like, you find something, and it's just given me the confidence to just ask, because the patients are rarely like upset with being asked. And also just within the society that I'm helping lead, like, the importance of all these things, not just for us but for other medical students, and trying to get more information out there for everyone else who can't take this course. Because I wanted to take it in third year too, and there wasn't space. And I've got so many friends who wanted to take it and there wasn't space. And then, I don't know, ultimately, like, the ones the people who want to take this course are maybe not the people who need to learn this information.
What a great we're working with the wrong thing. But I think what Shaq has taught me is to make, like, I feel very confident in doing the of the heads for pediatrics. I remember one time I was at RCH and there was a quite shy kid with autism, and then I was diving into the part and I was like, I've heard your mom said you were like writing stories about people you like who do you like? Girls, boys, both, neither, any? And then she's like, why does it matter? And I said, you're right. And then we talked a little bit more about that. I thought that was really good. But on the flip side, my first rotation after research was surgery, which is not my usual forte, but I'm really excited to talk to the post-op and be like, you just had really intense surgery. What are you peeing okay? Are you going to be intimate? And I'm excited to start those conversations that surgeons usually don't have.
Fantastic. I think that's time. So I just want to thank our four wonderful. I feel happy that the world has got you.